we all agree that breastfeeding is the optimum nutrition for young infants, not only for the physical, but also for the neurological and the development of the children. The WHO, the SPGAN, and all the international societies, they advocate exclusive breastfeeding for 4 to 6 months. And that's probably the best way to feed the infants. However, when the breast milk is not available or not sufficient, then infant formula is the only safe alternative to that. So, the floor is yours. We are looking forward to learn from your experience today.
Thank you for this very nice introduction, which says everything about my age. That's another way to say that I'm becoming old. But after the beautiful lecture, you heard about how important the good composition of infant formula is on functional gastrointestinal disorders. It is my turn to talk to you and to highlight some of the pitfalls in the management of functional gastrointestinal disorders. So this is the layout of my presentation, introduction. Let's talk a little bit about infant regurgitation, colic, functional constipation, and then come to conclusions. Whenever you talk about functional gastrointestinal disorders, you speak, of course, about the Rome 4 criteria. And they have been published in 2016. And what is a functional gastrointestinal disorder? Well, it is when, after appropriate medical evaluation, symptoms cannot be attributed to another medical condition than a functional disorder. It means you have to rule out mainly organic disease, of course. But on the other side, if you have an organic disease, inflammatory bowel disease or allergy, or even acute gastroenteritis, that does not exclude you of developing or having symptoms of a functional gastrointestinal disorders. So one does not exclude the others. And one is now one of those pitfalls of definition of functional gastrointestinal disorder. It's that by elimination of organic disease. But that means that not in every part of the world the possibilities to eliminate organic disease are the same. So what you consider elimination might be different from center to center or from country to country. Most guidelines do not recommend investigations for the diagnosis of functional gastrointestinal disorders. And that's also somehow, of course, contradictory, because on the one side you say you need to eliminate organic disease, and on the other side we say, well, functional gastrointestinal disorders are so frequent that you don't need to do a lot of investigation. So in practice, it's all about knowledge of the physician about alarm signs for organic disease and clinical practice. And whenever we discuss functional disorders, like in this presentation, we separate them one by one, but that's not how it presents in daily life for infants. So these are data from France in almost 3,000 infants, showing you that more than 3/4 of all the infants, more than 75%, present in fact with one or more functional gastrointestinal disorders at the same time. So it's 60% with 2, and it's 15% with 3 or more functional gastrointestinal disorders. So for the pediatrician in daily life, it's often not so easy if this is a crying baby because of reflux, or if this is reflux causing a lot of crying. And the same is true for constipation. So whenever you look at functional gastrointestinal disorders and you separate them, for instance, in those in dark gray having colic and those in light gray having no colic, then you will see that every functional disorder is much more frequent in those infants having colic compared to those who have no colic. So having colic predisposes to develop other functional gastrointestinal disorders. And then another important aspect is that Previously, it was frequently said, well, functional disorders does not matter because it goes over, colic disappears by 3 months, reflux and regurgitation decreases a lot after 6 months of age, and then it's over. Well, it's over, it's probably not completely true, because a functional disorder for an infant is correlating with feeding difficulties and causes often discontinuation of feeding. It causes parental stress and depression and insecurity of the mothers. It causes also behavioral and developmental changes for the child, and it challenges the family quality of life. And so even 3 years later, a family who had a crying baby does have consequences of that in its perceived quality of life, even years later. And whenever you had a baby as a functional disorder, you're at increased risk to have a functional disorder as an adult. Microbiota does play an important role in this, because illustrated in this slide that microbiota plays an important role in the genesis and maintenance of functional gastrointestinal disorder. And so healthy colonization of the gastrointestinal tract from birth onwards is very important. So let's have a look at the happy spitter, at the baby who regurgitates a lot. Nutritional management of regurgitation, that's done with thickened formula. And this is a study which is already quite old, 20 years old, but feeding with bean gum and galacto-oligosaccharides thickened formulas led to reductions in vomiting in infants with gastroesophageal reflux and significantly decreased the reflux index and the reflux episodes and duration of the longest episode. So it's not only decrease of symptoms, it's also decrease of measured acid reflux with thickened formula, with bean gum and with galacto-oligosaccharides. Illustrated also by this study from Thailand, more focusing on gastric emptying. So it's a 20 infants, it's an open study with this thickened formula, showing you that a lot of parameters, frequency of vomiting, volume of vomiting, coughing during the night, but also crying, colic and crying decreased significantly. Stool frequency decreased and weight gain was better. And you see here that baseline and bean gum thickened formula decreased the episodes of vomiting without having a clear effect on gastric emptying. So gastric emptying remains normal, but reflux, regurgitation and vomiting and other symptoms related to reflux decreased significantly. And this is then a more recent study which was done in the Philippines and which is a real-world study giving insight on reflux. So it's non-breastfed infants, almost 90 young infants, 40 older infants diagnosed with gastroesophageal reflux. And so it's 50 pediatricians who recommended the trial of regurgitation, anti-regurgitation formula in these infants, a trial with the formula thickened with carob gum and with galacto-oligosaccharides, and which was partially hydrolyzed whey. And what is interesting in this study is the demonstration on how fast the improvement goes with thickened formula. Of course, it confirms the data from all other studies that you effectively reduce symptoms of regurgitation and vomiting, but within 24 hours, there was already a clear decrease of frequency of regurgitation. So you do not have to try for 1 week or 2 weeks. You see the improvement very fast, and around 70% of the infants stopped regurgitation after 2 weeks trial of this thickened formula with partial whey hydrolysate, thickened with carob bean gum and with galacto-oligosaccharides supplemented in order to have the development of a healthy gastrointestinal microbiome. People from the Cochrane reviewed the existing literature on thickened formula and came to the conclusion that feed thickness can be useful in term formula-fed infants with troublesome gastroesophageal reflux. And troublesome gastroesophageal reflux brings me to the distressed infant. And as an example, Leilani is now 2.5 months old. She was term-born, formula-fed since the age of 1 month. And the parents consult you because she does cry a lot, mainly after each feeding. There is no explicit vomiting or regurgitation. She has consulted another healthcare provider 3 weeks ago who diagnosed this must be occult gastroesophageal reflux disease because she had a red throat. And a proton pump inhibitor, 10 milligrams per day, was started. And after some improvement the first 2-3 days, there was a relapse of the symptoms. And so the same healthcare professional was consulted again, and he just doubled the dose of PPI to 2 times 10 milligrams per day. And now you are seeing the baby, because there was still no improvement of the crying, it even got worse. Stools became more liquid and gassiness was quite important. So Leilani cried now for more than 3 hours a day, even during the night. And why do we always think that occult gastroesophageal reflux without vomiting, without regurgitation is a frequent cause of crying? There's one study we looked at this from now 15 years ago, looking at the percentage of time pH was below 4 and the duration of crying time. Now, if there would be a relation between both, your line would go in 45 degrees, exactly starting at 0, 0 and going this way. But the line of correlation is horizontal, which means there is no correlation at all between crying time and results of pH monitoring. So you have a lot of babies who cry a lot, who have no reflux at all, and you have babies with severe abnormal pH monitoring who do not cry. And this is also illustrated in this study from our center, which is now in press, but showing you in fact that in infants who do regurgitate and vomit and who do have abnormal reflux investigations and who cry a lot, that non-acid reflux is causing much more distress than acid reflux in our infants. So acid reflux is not the big problem, which is confirmed by this review of the literature showing that there is no effect of proton pump inhibitors on crying time and irritability in infants. Moreover, proton pump inhibitors do have a lot of adverse effects which are relevant to our infants. First of all, about 20 to 30% develop small intestinal bacterial overgrowth, and so they develop gassiness, colics, cramps, diarrhea as a consequence of blocking the gastric acid. Exactly the same symptoms as the reason why the proton pump inhibitor was prescribed. But proton pump inhibitors also decrease nutrient absorption. What has been shown is a decreased calcium absorption, and those infants are also at increased risk for iron deficiency anemia and vitamin B12 deficiency. So there are also nutritional disadvantages of proton pump inhibitor prescription, especially when it's of no use. So what can you use for distressed infants? Well, you could use proton pump inhibitors, but that's shown to be no effective. But probiotics, Lactobacillus reuteri, has been shown to decrease infantile colic, especially in breastfed infants. I will come back to this slide because the green studies, the positive ones, are all in breastfed babies, and the negative study is in formula-fed babies. Now, this study with a low level of galactosaccharides in infant formula has been shown to stimulate the growth of intestinal bifidobacteria and lactobacilli, and to normalize the gastrointestinal tract colonization. So what it shows is that with GOS, you get more bifidobacteria, more lactobacilli, than with control formula, and it's similar almost to the presence in human milk. And the fecal concentration of acetic acids and pH values are much closer with your GOS supplemented formula than with control formula to human milk. So Lactobacillus reuteri has been shown to be effective in the management of infantile colic with breastfeeding, but dietetic interventions have been shown to be effective in the management of formula-fed infants with diets which are effective in the treatment of constipation and normalize the gastrointestinal microbiome. And drugs have been shown to be not effective at all. So that brings me then to functional constipation. And now let's take Irene as an example. Irene is now 2.5 months old. She was term-born. She's formula fed since the age of 1 month, and the parents consult because she does have hard stools, what makes her very distressed. And they have applied abdominal massage, but without any success. So here you see the house remedies for constipation, which most of them do not really help and are not recommended. But let's go back to our formula supplemented with galacto-oligosaccharides, which stimulates the development of bifidobacteria and lactobacilli, and the effect on stool consistency. The effect on stool consistency is that with the GOS formula compared to the control formula, you get a lower stool consistency, which is the same as the stool consistency in human milk. So it's an effective treatment of constipation. What brings me to the conclusion of my presentation. Management of functional gastrointestinal disorder. It's a lot to do with parental perception, and parents always think it's much worse than it is in reality. So coping with them, reassuring them, showing empathy is certainly important. And breastfeeding is, of course, the best way to prevent functional gastrointestinal disorders, and breastfeeding should be always stimulated maximal. But for functional gastrointestinal disorders, time is in part a cure to go make the symptoms go better. Do not forget about the long-term consequences of functional gastrointestinal disorders. That's why effective management is important. Reassurance is important, but dietary treatment has been shown to be effective and to be safe. And postpone medical treatment as much as possible, because it's not about disease, and drugs are indicated to treat organic disease, and a functional disorder is not an organic disease. So our role whenever we see parents with a child with a suspected functional gastrointestinal disorder, our role as a healthcare professional is to always educate and reassure, to stay away from medication, and to use nutritional treatment to bring reassurance to those parents. And then you will make the infant symptom-free and happy, which will result in less clinical consultations, less healthcare costs, but it will also result in happy parents, and at the end also then a happy pediatrician, because the parents are happy and satisfied with your effective and safe intervention. And with this, I would like to thank you for your attention and give the word back to our moderator, Professor McDaddy.
All right, fantastic. We have 2 questions from one of our colleagues. I will try to say his first name, Nairako Steven. The first question for Ivan is asking you, very interesting presentation, if you have the option of choosing one of the following 2 products. Product A contains prebiotics and product B contains probiotics. I assume it's an infant formula. Which one would you prefer, Ivan?
Shall I give the political answer? I would prefer the formula with the symbiotic, the pre and the probiotic. But I would say that overall, I think prebiotics have the advantage to stimulate the development of the whole gastrointestinal microbiome of the host, while with probiotics you give specific strains. I would, of course, in the prevention of functional disorders, I think that prebiotics is a much more logic choice than probiotics. And in treatment, you have to choose what has been studied and that product for which there is most evidence of benefit. And there is quite some evidence that, for instance, to manage constipation, that formula supplemented with prebiotics is quite effective.
Is it true to prevent colic in an infant, there should have no bubbles in the bottle? I assume the proper way is to mix it, shake it, or stir it. So she's asking, do bubbles in the bottle affect the colic? And would you recommend shaking the milk, stirring it, or mixing it?
Yeah. Well, I think that every company has for every formula its own recommendation on how to prepare the formula. In general, it's rolling it over to mix it, what is the recommendation for most of the formulas. And one of the reasons of crying is swallowing excessive air, of course. So avoiding the ingestion of excessive air is certainly one way to prevent colic.